Okay. Hey guys, welcome to the liver session. Why don't we get started on the small group questions now? If anyone needs the small group, just ask one of the chiefs or email me. Okay, it joins the left hepatic vein 1 centimeter before the IVC in 85% of patients. Right here, this is what they're talking about. And then the left hepatic vein, it runs between segments 2 and 3, then the left intersectional plane. So these are easily testable points, and they're really important to know. So just remember where middle hepatic, right hepatic, and left hepatic go, and where the portal vein goes. Hepatic hilum. So this, it's basically a plate system. It's a fibrous sheath extending from the hepatoduodenal ligament, which forms the portal pedicle. You can see it isolated, and you can see it in vivo. Portal vein. So it provides 75% of the blood flow to the liver, 50% to 70% of the oxygenation. It's a low pressure system, 5 to 8 millimeters of mercury. The extrahepatic length of it is 5 to 8 centimeters with a diameter of 1 centimeter. The IMV joins the splenic vein, and splenic vein and this SMV coalesce behind the head of the pancreas to become the portal vein. So you can see splenic, IMV, SMV, then we have the portal. And remember, the portal is going to go up between segments 5 and 8 and 6 and 7. Hepatic arteries. So these provide 25% of the blood flow and 30 to 50% of the liver's oxygenation. There's frequent variations. So in the anatomy of the hepatic arteries, and these are very testable. If there's an additional artery supplying one part of the liver, it's called accessory, in additional to the normal anatomic artery. If it's coming from a different origin without a normal anatomic supply, it's replaced. So here are our variants. We'll go through them, then we'll circle back. So this is in normal anatomy. And then, so you can see here, just the normal, and then replaced or an accessory right hepatic artery. So replaced hepatic artery, this is when it's taking origin from this SMA. So here we can see that. So that is a replaced hepatic artery. It's not coming from the normal location. So then we have replaced left hepatic artery. So replaced left hepatics comes from the left gastric. Replaced common hepatic would come from the SMA as well, which is it's very rare, only 2%. If the right hepatic crosses anterior to the common hepatic duct, that's around 20% of variations, and you can see it here.
Sorry to interrupt. Can you go back to the replaced right for a second?
Which one?
Replaced right.
Yeah.
So, so I think this question came up every year when I took the exam. They're never going to ask you about where it's originating from directly. They will give you an example of like you dissecting along the hepatoduodenal ligament, and then there is a pulsating structure lateral to the bile duct. So this is how they present it. And then you have to say, okay, it's coming from the SMA. But this question came up every year.
Okay, thank you. It's really helpful. So they'll ask about a replaced right hepatic. They'll say pulsating structure lateral to the bile duct. Okay. Next, so let's go back here. One other thing that I want to go over is how do you look at the liver from a radiologic standpoint? So intraop ultrasounds are actually the most sensitive imaging for liver masses. Ultrasound elastography detects the degree of fibrosis and cirrhosis. For portal veins, you can see an echogenic glycogen sheath on the triad structures. So on ultrasound, they will look kind of shiny. If you see here on the portal structures, they look shiny versus here, which are just normal veins that are not shiny. That's an easy way to tell the difference between the two. So here's a mini review on segmental anatomy on CT. Why don't we start with team 3? Do you want to tell me, starting from the left slide, the segments that, like what these structures are, what these that are identified?
So the left portal vein, the right portal vein.
It's not working. Oh yeah.
Hello?
Hi, I can hear you, yeah.
The left portal vein, right portal, or, middle hepatic vein, and then the left hepatic vein.
Yes, exactly. So it's the right hepatic, middle hepatic, and left hepatic. Great. What about picture B? What about team 4? So what segments are these? How about we do that? What segment is this? What segment is this? What segment is this? What segment is this? What segment is this?
Can you hear us?
Yeah, we can hear you.
Is the bottom one 7?
Yes, love it. What's next? What's this?
8.
Yeah.
And then we're gonna go like 4A,
Yes.
and it should be 2. 2.
Yes. And then there's 1. Okay. Team 5, do you want to then tell me what segment this is?
Six, 5, 4B, and 3.
Yes, good job, guys. Moving on. So the liver is a functional unit, and we can think about it in lobules and zones. For the hepatic lobule, the central hepatic venule is surrounded by 4 to 6 portal triads. The blood flows through the endothelium-lined sinusoids, which are bordered by hepatocytes. Bile is formed within these hepatocytes, which then goes to terminal caniculi and then the bile ducts. Sinusoidal endothelial cells are separated from the hepatocytes by the space of Dease, which is perisinusoidal space. In terms of zones, zone 1 is periportal, and it is the most susceptible to toxins. Zone 2 is intermediate, and zone 3 is perivenular, and it's the most susceptible to the ischemia. So you can see in zone 3, central lobular necrosis. Physiologic functions of the liver. So it's responsible for energy production, glucose via glycogenolysis and gluconeogenesis, creates acetoacetate by beta oxidation of fatty acids. In terms of synthesis, it creates albumin, acute phase reactants, and coagulation factors, specifically those vitamin K dependent factors like 27, 9, 10, protein C and S, and glutamyl carboxylase. A point is that von Willebrand factor and factor VIII are not made in the liver, rather they're made in the endothelium. It's responsible for bioproduction and secretion. It stores one water-soluble vitamin, B12, metabolism, bilirubin, carbohydrates, lipids, proteins, vitamins, and toxins. It is responsible for phase 1 reactions. So oxidation and reduction by cytochrome P450, which increases water solubility. In phase 2, conjugate reactions, and it generates less active byproducts. So let's do a quick review on anatomy. What is the origin of an apparent right hepatic artery, Elmhurst?
Can you hear us?
Yep.
Yep. The SMA.
Love it.
Oh my gosh, it's not me.
Do you want to do the first half of this, and we'll switch to Surgeonc for the last 4? So origin of left hepatic artery.
Left gastric.
Yes. Found where?
Just lateral to the common bile duct.
In gastrohepatic
Gastrohepatic.
liver. I didn't specifically say that. So most primary and secondary liver tumors are supplied by what?
Hepatic artery.
Yes. And
So hold on. So this is important because when we want to treat like cancer, we can use like local regional therapies and just embolize the arteries without like causing any liver dysfunction.
yep, thank you. And then separating the left and right lobe of the liver.
The middle hepatic vein.
Yes, okay. Surgeonc, do you want to take over for the rest of the slide?
Only water-soluble vitamin is B12. Clotting factors not made in the liver are von Willebrand's and factor VIII, which are made.
Yes. So here's a bonus point. What is the blood supply for the caudate lobe? I don't think I didn't specifically say this, but if anyone knows.
Left and right hepatic.
Yes.
IVC. I heard a yes.
Well, right and left hepatic, what?
I said vein.
Close.
No.
Portal vein and right and left hepatic arteries. Cool. Moving on to the actual hepatic lesions part of the talk. So there's benign, malignant, and metastatic. Benign is actually the majority of what we're going to be talking about. So benign lesions are in 7 to 20% of the population. Most are found incidentally on workup for unrelated cross imaging. Reasons to work these up. Some have risks of malignant transformation, hemorrhage, or rupture. Most have a characteristic appearing on imaging, which is very testable. If you misdiagnose these, there's risks. They can have unnecessary surgery and incorrect staging in patients with non-liver primary cancer. So when you're thinking about a benign lesion, what are your modes to evaluate them? Ultrasound is accurate, fast, and non-invasive. CT is pretty good for it, especially in the right phrases. MRI is more sensitive in detecting variations in liver parenchyma. It has no radiation, may not be readily available though. And biopsy is really rarely required because the imaging characteristics are so consistent. So first, let's talk about adenomas. These are well circumscribed tan lesions comprised of sheets of mutated hepatocytes with minimal atypia, with glycogen and lipid deposits, without bile ducts, and rare capsules. The problem with these is that they can proceed to hemorrhage, and because there's no capsule, you can spread to like hemoperitoneum, or central necrosis are common because it outgrows blood supply. It does have a risk of malignant transformation to HCC, it's more likely it's greater than 5%, which is an important point. So let's just look here. An adenoma on ultrasound is well circumscribed, sorry, post-call Elmhurst, well circumscribed, heterogeneous, and variable echogenicity. CT it's a hyperattenuate arterial phase with loss of contrast on delayed phase. And MRI, it's iso-intense to hyper-intense. I'm just going to show you some pictures. So this is a 21-year-old female with 2 large adenomas with focal areas of hemorrhage. On T2 of the same weighting image of the same lesions, it has mixed hyperintensity signals that correlates with region of hemorrhage. These are most common in females 20 to 40 years old. They're associated with OCPs and steroids classically, and the risk increases with longer duration. Newer cases though, because the country is becoming so obese, obesity is actually a big related, and like the comorbidities of liver related complications like fatty liver disease and non-alcoholic steatohepatitis, and also glycogen storage diseases. Most are asymptomatic, found incidentally. If they are symptomatic, they are large and they can present with rupture or hemorrhage. These are 4 types. I don't think it's that high yield, but we can quickly go over them. Hepatocyte nuclear factor related ones are 33%. They're spontaneous and they have low malignancy risks. There's beta-catenin active type where there's more atypia and they're more often in males. If they're neither mutation or non-inflammatory, they are the highest risk of spontaneous rupture. And but if they're not mutation, but they are inflammatory, those are about 50% of adenomas, and they are associated with JAK-STAT mutation and fatty liver disease. So management of these. Less than 5 centimeters and asymptomatic, you should stop OCP or steroids and manage their obesity. If it grows despite management or it's greater than 5 centimeters, you do a resection, reduce the risk of hemorrhage or malignant transformation. You treat these similar to malignancy. You want negative margins and you use an intraop ultrasound to achieve this. Let's say you have smaller multiple lesions, you can do RFA. And in the case of active hemorrhage, you can embolize them with elective resection during the same hospitalization. FNH.
Sorry, just to add on. So I think for the exam, stop the OCP and then resect for anything that's above 5, especially in a childbearing woman. But in reality, these are inflammatory. So we don't try not to resect unless they're like symptomatic or really large and the patient wants to become pregnant. But they're inflammatory, they don't contain the beta-catenin gene. So if anything, that beta-catenin is very important to remember because it's associated with malignant changes. In male who have adenoma, because there's a higher risk of malignant changes, we do resect. But more and more, we try to avoid resection in adenomas. But for the exam, I think just resect if it's over 5 and symptomatic.
Okay, great, thank you. FNH. So these are the second most common benign lesion. They have no malignant potential, no risk of rupture or hemorrhage. They are hyperplastic proliferation of normal liver parenchyma around a fibrous scar. So it has Kupffer cells, which means they have sulfur colloid uptake on liver scans, which is something that we should remember. They're mostly single and less than 5 centimeter. 20% of these are atypical without a central scar. So on ultrasound, it's variable and you rarely see a central scar and it's unreliable. On CT, they're hyperattenuated on arterial phase, and the central scar remains enhanced during the venous phase. They does lose contrast enhancement in delayed phases. So I have some pictures coming up, but on T1, it's hypo-intense throughout, but on T2, it's hypo-intense with a hyper-intense central scar. So, so A, we see hypointense throughout on T1 weighting imaging. So this is the area in question, but then we switch to T2 and we can see that central scar. When we look at CT on the arterial phase, so it has, the classic thing is early arterial enhancement with rapid washout. During the venous phase, FNH is isointense while the central scar remains enhanced. Here's a more classic picture, but we won't always see that. But I think on the exams, they usually go for the central scar. They're more common in women 20 to 50. There's no link to OCP, but it's possibly estrogen responsive. It's an incidental finding. There's no need for biopsy. If they are asymptomatic with classic imaging, conservative management is appropriate. Resection is rarely done, but I guess if it's symptomatic or you can't rule out malignancy, that's the only way that you would go for that. Next is hemangioma. So these cavernous venous malformations, they have an endothelial lining and they are blood filled. These are the most common benign lesions. They're male to female 3 to 1, 20 to 50 years old. They're mostly single, but 10% are multifocal. They're almost always usually found incidentally. The majority are asymptomatic. They have no metastatic potential, low risk of rupture. They do have a slight predominance to the peripheral right lobe. If they're greater than 5 centimeters, you can have pain, early satiety, and nausea. If it's greater than 10 centimeters, it is technically a giant hemangioma. So on ultrasound, hemangiomas appear as well demarcated, homogeneous, and hyperechoic lesions with posterior acoustic enhancement. On CT, they are well circumscribed, hypodense lesions with non-contrast. And on MRI, hemangiomas are well demarcated homogeneous lesions that are hypointense on T1 and markedly hyperintense on T2. And after contrast injections, you can see asymmetric peripheral pools of enhancement during the arterial phase, followed by progressive central pedal enhancement in washout on delayed phase. And that's pathognomonic, and that's kind of what they go for. So it's central pedal enhancement and washout on the delayed phase. And you can also see this on CT with contrast, by the way. So here it is, hypointense on T1, and then hyperintense on T2. And then we can see here the central pedal filling. So at 1 minute, you can see the contrast here, but then over time, as it works its way through all the vasculature, it starts to fill centrally. For hemangiomas, resection is rarely indicated. Obviously, if symptomatic or showing growth or ruptures, which is extremely rare, you can do enucleation, wedge, or formal segmental resection. You can embolize before resection to shrink the lesion or control potential bleeding. So transplant, very rare. It can happen for large symptomatic ones. Kasabach-Merritt syndrome is something that can develop. It's a hemangioma thrombocytopenia syndrome, and you're going to see coagulopathy and hypophyginonemia. So basically, they just become coagulopathic because everything's just being consumed within the hemangioma.
So just a few things. So never biopsy. Okay, these are extremely vascular, and you may encounter hemorrhagic bleeding. They usually tend to regress after menopause. And then one of the things for the exam, I've had it once. They had a hemangioma with a patient who had a low platelet associated with the Kasabach-Merritt syndrome. So just keep that in mind. But overall, we do not do anything unless symptomatic.
You. Simple cysts. So these have about an 18% incidence. It's usually congenital, arising from aberrant bile ducts lacking communication with the bile ducts. they mostly remain stable in size, but they can grow from serous fluid accumulation. They're most diagnosed incidentally and are almost always benign. You can have symptoms from hemorrhage, infection, or rupture, which is usually when they're greater than 4 centimeters. So simple cysts, they generally lack septations on ultrasound. And in a majority of cases, actually, an ultrasound alone can be used to establish the diagnosis. So one thing is, like, we're going to talk more about something next, but if it has internal septations or a thickened irregular cyst wall with mural nodules, that's not a simple cyst. That's something else that is more concerning. On CT, simple cysts appear as well circumscribed, homogeneous, and hypoattenuated lesions. They don't enhance with contrast, obviously. T1, they're hypointense. T2, they're very hyperintense, would make sense because T2 makes fluid light up. And again, limited contrast enhancement, which makes sense. Here are the pictures of them. That is a cyst. So this is an MRI after cyst fenestration. So that shows residual fluid in the cyst cavity. These are non-operative. If they're less than 4 centimeters, with non-operative management, so less than 4 centimeters, you get an ultrasound every 6 to 12 months, looking for a rapid increase in size. You can stop if it's unchanged after 2 to 3 years. If enlarging or symptomatic, you can do cyst fenestration with an omental flap. According to the literature I saw, omental flap decreases the risk of recurrence, but still remains around 10 to 15%. You don't aspirate these because they're just going to reaccumulate. If someone can't have surgery, you could try sclerotherapy, where you drain the fluid and put in a sclerosing agent like ethanol. It's not an option in patients with cyst communication with biliary tree or with evidence of hemorrhage. It has a higher rate of recurrence than cyst fenestration itself. So let's do a quick review. Who is up next? I guess we went through everyone, so can we go back to team 3? Do you want to do the first 2?
Peripheral to central enhancement, hemangioma.
Yes, so no biopsy or treatment and was symptomatic. Enhancement of a central scar and delayed fade, CT.
Focal nodular hyperplasia.
Yes, it can be diagnosed by imaging alone. It does not need biopsy. Team 4, what is a thin-walled fluid-filled structure with no septations or calcifications on arterial face?
Cyst.
Yes, simple cyst. Does not require biopsy or treatment unless worrisome findings like septations, papillary projections, or calcifications. What about a well-circumscribed mass with bright enhancement on arterial face?
HCC.
Adenomas. No treatment if less than 4 to 5 centimeters. Okay. So well-circumscribed mass with bright enhancement on arterial face. Okay, why is it not? Sorry, it's not going to the next slide. Okay. Okay, biliary cystadenoma. These are rare, large, multiple cystic masses. They're more common in women over 40. They present with like symptoms of basically lack of space, pain, nausea, anorexia, distension. These are globular surface with multiple cysts and loculations that are filled with mucin. They are atypical columnar cells in a basement membrane. They are slow growing, but can grow to a cyst adenocarcinoma. Therefore, the treatment is resection. And that's why I said, like when we were doing simple cysts, if they have complex cyst walls, mural nodules, thickened walls, and papillary projections, that's not a simple cyst. This is something more concerning that does need to be treated surgically. And here is what they look like. So you see how like on simple cyst, it was just like one pocket, but this looks like way more complex and irregular. That is not normal, and that should be resected because of the risk of malignant transformation. Next, another quick review on benign image. So team 5, do you want to take these questions? So what is the most common benign hepatic tumor?
Hemangioma.
Yes, sorry, it's not working. Hemangioma, great. What does it look like on imaging?
Gonna have centripetal enhancement.
Yes. What is a treatment?
Nothing. No resection.
On the test, you might do it if it's symptomatic, but yes, no resection. What about a central stellate scar?
FNH.
Yes. What is the treatment? This is a trick question. Nothing. Is anyone in the surgery library?
Yeah.
Okay. Do you guys want to tell me what an obese woman on OCPs with a liver mass, what that is?
Adenoma.
Yes. Is there a risk of rupture?
Yes.
Yes. What is the treatment?
DC OCPs, and then if it's greater than 5 centimeters or symptomatic, you can resect.
Yeah. Oh, I wrote 4, but yes. 5. What about the globular surface with multiple cysts and loculations filled with mucin?
That's that biliary cystadenoma.
Yeah. And what do we do about that?
Resect because of malignant potential.
Yes, it's not working. Okay, exactly. Resection secondary to cancer risk. Perfect. Lastly, in terms of benign lesions, there's polycystic liver disease. It's associated with polycystic kidney disease. It's histologically similar to simple cyst, always preceded by renal cyst, actually. Presence increases with age, and it's usually asymptomatic, causes no liver dysfunction, rare bleeding or infection. If they're symptomatic, you can proceed with cyst fenestration. So let's switch over to malignant lesions. We're going to talk about HCC, intrahepatic cholangiocarcinoma, and then metastatic liver lesions. Basically, we're just going to talk about colorectal mets because they're the most common. So hepatocellular carcinoma, it's the #1 primary hepatic malignancy, causes 1 million deaths worldwide annually. It's up to 8 times more common in men. Risk factors: HBV, HCV, obesity, NASH, smoking, cirrhosis, hemochromatosis, aflatoxin, alpha-1 antitrypsin, Wilson's disease. In the absence of cirrhosis, it's usually associated with HBV or fibrolamellar HCC. And those are actually more common in patients with no underlying liver disease. HBV causes more cases traditionally than HCV. Diagnosis. So here's what some imaging it looks like on imaging. But so first, the AFP, the specificity, if elevated AFP is associated with it, specificity and positive predictive value increase when it's over 400. It's used as an adjunct to diagnosis. It's not specific to HCC, but it is elevated in 50 to 75% of cases. Imaging, you do triple phase CT and MRI. CT alone for lesions greater than 2 centimeters may be diagnostic of classic findings. On CT, you're going to see a heterogeneous, poorly circumscribed mass with bright arterial enhancement and quick washout. So you can see there's this bright mass and portal, and then it's washing out on the delayed phase. So bright arterial enhancement and quick washout. There's some tumor types. I think this is fairly low yield, but I have it here. So there's well, moderately, or poorly differentiated. There's a hanging type, which is pedunculated, a pushing type, which is well demarcated with fibrous capsule, which displaces vascular structures, infiltrative type, which is invasive, which makes sense, and multifocal. I talked about this briefly, but there's variants. So the fibrolamellar is well encapsulated with the central scar. So it's really difficult to differentiate with FNH. You can have mixed hepatocellular, cholangiocellular. It has the worst prognosis than HCC alone, but better than cholangiocarcinoma. So it's sort of like halfway between the two. There's clear cell, pleomorphic giant cell, sarcomatoid, and childhood HCC actually has a pretty poor prognosis. It's usually multifocal with vascular invasion and extrahepatic mets. So looking at the HCC versus the fibrolamellar, which is the one that's difficult to differentiate from FNH. You can just, I don't know. So they're more, HCC is more common in older patients versus fibrolamellar is more common in younger patients. HCC is normally invasive, while fibrolamellar is well circumscribed. HCC is less often resectable than fibrolamellar. HCC is more often to be associated with cirrhosis, positive AFP, and Hep B.
Yeah, just remember, like fibrolamellar has a better prognosis, so it will be at a younger age. The tumor will be well differentiated compared to poor, has higher, chances of resectability, will have less cirrhosis, better AFP level, and so forth. So just think about that way.
Yeah, thank you. So preoperative assessment for patients with HCC. You get a chest CT. Common locations for METs are lung, bone, peritoneum. You don't do a routine bone scan unless symptomatic. You get LFTs. Portal hypertension, if that is there, it's predictive of post-op liver failure and death. Cirrhosis, in terms of trials A, B, and C are associated with 5, 30, and 80% mortality. So, and you do proceed with a staging laparoscopy.
And how do you diagnose portal hypertension?
Portal hypertension, it's, well, you can do a clinical diagnosis, or you can do the wedge pressure in the portal vein.
And clinically, what do you see?
You can see varices, you can see caput medusae, you can see ascites, all sorts.
Yeah. And then low platelet count on the blood work.
Yep. So for staging, so TNM is actually not routinely used because it doesn't take liver function into account. It relies on pathology, and there's a lot of scoring systems, which I'm not going to get into here. Treatment options are surgical. Surgical is actually the only curative one. You can, in certain circumstances, offer someone a transplant. You could also proceed with ablation, which induces necrosis with ethanol or heat. You can have embolization, radiation therapy, or systemic. Chemotherapy has poor outcomes, but there are some molecular target immunotherapy. Like I said, surgery is the treatment of choice.
So all these are curative treatments that you just presented. So resection, transplantation, or ablation, if it's less than 2 centimeters, are curative.
Mm-hmm. Okay, thanks. So surgical resection, OLT, and ablative if less than 2 centimeters. If someone has classic risk factors, classic imaging, and elevated AFP, you don't need a biopsy. There's a small risk of seeding or bleeding, and it's not going to give the patient benefit. There's about a 5% mortality in healthy patients with Child's A and no portal hypertension. One thing to remember is you need to think about the volume of future liver remnant. If someone has a healthy liver, you can leave them 20% and they should be okay. You can leave them 30% if they have minimal liver dysfunction or chemotherapy injured. if you can also do portal vein embolization for functional liver remnant under 40%. Poor prognostic indicators, pretty self-explanatory. Cirrhosis, portal hypertension, tumor size, if it's multifocal, if there's METs, margins are less than centimeters on resection, and no capsule. And then the best prognostic indicator also makes sense, single small lesion. The question of transplantation for HCC.
So let me just go back 1 second. So resection, because they will give you a scenario of either choosing resection versus transplantation. They will make it easy. But remember, resection is someone who can tolerate it, does not have many comorbidities, who has good liver function. So check the bilirubin level, make sure there's no portal hypertension. Again, I summarize, you should have like normal platelet count, no ascites, no varices, etc. You can have cirrhosis, but it has to be child A. No child B, no child C should be resected. And it should be a single lesion. So if a patient can tolerate with good liver remnant, you resect.
Okay, great. And you said child A, like child A has a 5% mortality, but you go to child B and it jumps to 30%. Then child C, it jumps to 80%. So that's way too high. So in terms of transplantation, this is related to the article that we're going to talk about. But so patients, so basically the criteria, which is established in the paper we're going to talk about, if a patient has a single early stage tumor less than or equal to 5 centimeters or 2 to 3 tumors, none of them exceeding 3 centimeters, and without lymphovascular invasion, you can proceed with resection. UCSF is a little bit more liberal. Single tumors less than or equal to 6.5 centimeters or 2 to 3 lesions, not exceeding 4.5 centimeters, with a total tumor diameter less than or equal to 8 centimeters. And again, no lymphovascular invasion can be present. Next is intrahepatic cholangiocarcinoma. It's the second most common primary hepatic malignancy. 10% of cholangiocarcinomas. It's related to similar things like HPV, HCV, NASH, diabetes, PSC, which has an 8 to 20% lifetime risk, or choledochal cysts, which has a 3 to 28% lifetime risk. There's 3 subtypes: mass forming, intraductal, and periductal infiltrating, which has the worst prognosis and is unfortunately the most common. On CT, it shows a low attenuating lesion with minor peripheral enhancement and upstream biliary dilation. It's usually advanced in presentation. It has vague symptoms. It's less likely to present with jaundice. It's a diagnosis of exclusion because if you get a biopsy and it shows adenocarcinoma, adenocarcinoma is more common as a metastasis. Treatment is resection with a portal lymphadenectomy, but the 5-year survival rate is pretty low, 40 to 60%, which honestly is higher than I was expecting to see. Lastly, let's talk about METs. So these are the #1 liver malignancy. GI METs, it happens through portal seeding, but you can also get GU, gyne, melanoma, breast, sarcoma, and neuroendocrine tumors metastasizing to the liver. Colorectal METs, you can resect these and still have the patient have great long-term survival and cure. So on CT, they're hypoattenuated on CT minus, but contrast reveals peripheral enhancing hypoattenuated lesions. So you can see there, peripheral enhancing hypoattenuated lesion, and they're all over the liver. So that's pathognomonic for a MET. They, however, in the presence of hepatic steatosis, you may have iso or hyperattenuating. Versus a hemangioma, they may show centripetal filling, but these will have washout on delayed phase. Some primaries produce hyperattenuating lesions like RCC, thyroid, and neuroendocrine tumors. I don't know if that's too relevant, but just an interesting fact. On MRI, they're mildly hypointense on T1, moderately hyperintense on T2. So you can see T1 and T2. Eovis contrasts. METs do not retain any Eovis contrast on delayed phase, so they look like little holes in the liver. Fluid filled levels are considered specific for neuroendocrine tumor METs. So colon cancer, it's a #3 malignancy. We can go about this later, but you know, it's 5 to 10 of these patients have cure for resection. Up to 50% of patients will have liver mets at presentation. Obviously, you need a full workup before resection to assess for location and size on CT, hypovascular and hypodense on portal venous stage. The goal of resection here for metastasis is for removing the mets is microscopically negative margins. It can be resected at the same time as the colon or separate. If someone has a new liver lesion on CT after primary resection malignancy, you still want to work that up. Things that are poor prognostic indicators: if it's greater than 5 centimeters, more than one lesion, if the disease-free interval is less than 1 year, lymph node positive, CEA greater than 200. These are all very self-explanatory. Extrahepatic lesions are also not absolute contraindications if they're also resectable. Like if you can just get a wedge resection of a lung met, this is still potentially curable. These do have a high recurrence rate. Only 5% of candidates are usually qualify for a secondary resection. So our 5th quick review, actually, it's not our 4th. So team, who's up? Surjonk, do you wanna, what is a low attenuated lesion with mild enhancement on arterial phase?
HCC?
Yes. No, sorry, metastatic lesion. You should biopsy that. What about a hypovascular and hypodense lesion on portal venous phase?
It's like colon cancer, but I don't know.
Yes. Metastatic lesion also. So that's what it looks like on arterial. That's what it looks like on venous phase. You should biopsy this. What about the appearance of HCC?
Arterial enhancement, rapid venous washout.
Right, arterial enhancement with quick washout. Perfect. Do you remember the Milan criteria?
Single lesion less than 5 centimeters, 2 or 3 lesions, 3.5 centimeters, and no like vascular lesion or extrahepatic red.
I don't think so.
I heard it.
Sorry. So no single lesion greater than 5 centimeters, or 2 or 3 lesions greater than 3.5 centimeters, or lymphovascular spread or extrahepatic lesions.
Yes, it's 3 tumors, all less than or equal to 3 centimeters. Not 3.5. Do you remember what the goal of resection was in metastatic lesions?
Oh, microscopic, negative microscopic.
Yes. And do you remember the volume of future liver required for resection? So it's going to be, if a patient has a healthy liver, 20%, 30% if minimal dysfunction, or if the liver has been injured by chemotherapy. Okay, so that is all our malignant lesions. We were supposed to also review hepatic resections. So let's go through this pretty quickly so we can do journal club. So anatomic resections. So it's functional segments with defined borders based on blood supply. Terminology, there's right hepatectomy, which is segments 5 through 8, left hepatectomy 2 through 4, then sectionectomy 2 through 3, 4 and 5, or 8, 6 and 7. We'll go through these again. So the outdated terms are lobectomy, triseg, or left lateral segmentectomy. You can do anatomic or non-anatomic, laparoscopic or open, where you would always explore the entire abdominal cavity for METs. intraoperative ultrasound is really useful. You can assess for the location of lesion and vascular structures and to look for lesions that were not seen on imaging. I'm going to skip over some of that stuff. The basics of hepatic resections are inflow control, which results in vascular demarcation, which you can use for your wedge resection. The Pringle maneuver is an important thing to know. You can decrease blood loss during parenchymal dissection. That is when you just clamp across the portal triad. You can do it for 15 to 20 minutes at a time with 5-minute breaks. To do a parenchymal transection, you can finger fracture, clamp, crush, do water jet, ultrasound energy, bipolar ultrasound, or argon beam. Here's just some pictures of a right hepatectomy, which is segments 5 through 8. So you take down the coronary ligaments, retract the right liver, dissect the IVC ligament and transect it, which will reveal the right hepatic vein. Then you go transection of the right chorda and right hepatic artery, which demarcates the dissection plane. The duct should be left to dealt with until after the parenchymal dissection. I know. And here's just another view of what these look like. So right surgical segmentectomy, and then a left surgical segmentectomy. I think this is probably the last thing we should go over. So a right hepatectomy is segments 5, 8, 6, and 7. Left hepatectomy is 4, 2, and 3, also part of 1 in each of these. Extended right is the same plus segment 4. Extended left is a left hepatectomy plus the next segment over, so 8 and 5. And then there's a left lateral segmentectomy, which is 2 and 3, and then right posterior 7 and 6. I know this is a lot of information and there's a lot of buzzwords. Here's what a left hepatectomy looks like. So I appreciate everyone paying attention. Why don't we take a 5-minute break and then we'll go over the paper that established the Milan criteria. Oops.